I'm Dr. James Weinstein. I'm a retired neurosurgeon. After retiring, I worked at Marshall University and started doing Alzheimer's research. The product of this research is an article in Medical Hypothesis, volume 109, 217, pages 53 and 55. This talk is a summation of that article. It is indisputable that there is no currently effective therapy for Alzheimer's disease. An effective therapy being defined as a complete cessation of progressive dementia. Why can't a cure be found? The answer is that late onset AD is caused not by one, but by four separate distinct pathologic processes. Current treatments have been aimed primarily at only one or another of these four causes of the disease. Even if effective, the inhibition of a single etiology does not necessarily inhibit the others from continuing their inexorable destructive course with the continued death of the cells of the thinking brain. The four distinct damaging processes are: 1. Cerebrovascular insufficiency, a major cause of associated mitochondrial dysfunction. 2. Damaging protein inclusions. 3. Uncontrolled oxidative stress. 4. Neuroinflammation, where pro-inflammatory damage from dysfunctional microglia and astrocytes are damaging to cells. Discussing these, we start with mitochondrial dysfunction. As reported in Nature Communications in June of 2016, researchers at McGill University evaluating available diagnostic parameters in 1,071 AD patients found that a marked decline in the brain's blood flow is the earliest symptom of AD. Alive and his associates described this vascular hypoperfusion and oxidative stress as being key initiators for the development of AD by causing mitochondrial dysfunction. This dysfunction results in a diminished production of necessary ATP production and an excessive production of reactive oxygen species. The latter, if uncontrolled, leads to oxidative stress. Swerdlow and Kahn have described a well-supported mitochondrial cascade hypothesis for sporadic AD, detailing this process. The second pathologic cause is damaging protein inclusions. Amyloid plaques and phosphorylated tau tangles are found in all AD patients. In addition, Lewy bodies of Parkinson's dementia are found in 50% of AD brains, and phosphorylated TDP-43 inclusions are found in frontotemporal degeneration, also found in 50% of AD patients. A damaging effect from these inclusions must be considered. Oxidative stress is the third pathologic process. Oxidative stress is a physiologic process necessary to protect cells, particularly from infection. However, if this process is not controlled, which may occur in the aging brain, cellular elements, protein, lipids, DNA, can be oxidized and so destroyed. Glycooxidation may be advanced in Alzheimer's disease with the release of oxidative species. This is seen in AD to be significantly increased, perhaps 50 times in certain cases. The fourth process is pro-inflammatory effects, which are due to aging damage to the microglia and astrocytes, where Pro-inflammatory processes replace the usual anti-inflammatory effects of these cells. If we accept these four pathologic processes are combining their damaging effects to produce the death of neurons in Alzheimer's disease, a conclusion may be reasonably reached that an effective therapy would best inhibit all four of these processes. A combination of treatments together accomplishing this goal is the most likely means to achieve this aim, rather than searching for a single agent effective against all four pathologies. The latter approach has been shown to be ineffective. Four drugs and a vitamin have been identified in the medical literature which together should serve as an ideal combination to treat Alzheimer's disease. All four drugs are standard medications used for various clinical purposes and would be used off-label to treat AD. All four have been tested in preliminary clinical trials to inhibit dementia, with all showing general beneficial effects. All four tested in preclinical studies inhibit one or more of the four major pathologies producing AD. Together they inhibit all four. Let us review the members of this combination and the evidence for their effectiveness. Trentol is a standard treatment for general vascular insufficiency and is used for vascular dementia. Oral Trentol was evaluated for 9 months with vascular dementia in patients with conclusion that the treatment is effective, indicating a beneficial effect for hypovascular circulation to the brain. Trentol has also been shown to inhibit glycation so as to inhibit secondary oxidative stress from the advanced glycation end products. Trentol has been suggested as inhibiting release of pro-inflammatory cytokines from microglia. Nisergaline has been used to treat senile dementia as it decreases vascular resistance and increases arterial flow to the brain. There is also a report of nisergaline acting against neuronal cell death induced by activated microglia and astrocytes. This effect occurs by the suppression of pro-inflammatory cytokines and enhanced brain-derived neurotrophic factor. Methylene blue is used to treat methylglobinemia and other medical conditions and has been found to preserve mitochondrial production of ATP and reduce production of reactive oxygen species. It has been tried in treatment for Alzheimer's therapy with some provisional success. The drug has also been reported to inhibit phosphorylated tau production. A third combination is nilotinib. It is a chemotherapeutic agent used for treating chronic myelogenous leukemia and has also been found uniquely to stimulate the formation of parkin, a protein which clears protein inclusion from cells. Nilotinib is used at 1/4 of the chemotherapy therapeutic dosage for the purpose of clearing damaging inclusions. It has been used in a preliminary study with Parkinson's patients and found to be effective with one patient of 12 only, requiring discontinuation of therapy over 6 months. Pyridoxamine, a B6 vitamin, is the fifth member of the AD combination, acting against pathologic glycation and oxidative damage. Drug dosage and possible side effects are discussed in the published article. Considering that the beneficial effects of the selected members of the chosen combination will summate their benefits, and that all four of the major pathologies causing AD are inhibited by the combination, it is reasonable to presume that this specific combination will be effective through a year to a year and a half to achieve the chosen endpoint of completely stopping progressive dementia in AD patients. The point of a chosen endpoint completely stopping progressive dementia identifies another change from standard methodology for testing new AD therapies. As noted, the standard approach is to find a single therapy which is effective but not in completely stopping progressive dementia, but rather only slowing rate of progression. This requires a statistical measurement of up to 2,000 patients, including those treated with placebos. This is an extremely expensive process. To date, it has been unsuccessful, and the chosen endpoint is futile in achieving a worthwhile treatment of the disease. If cognitive decline can be stopped, there is a chance that the patient's cognition may eventually recover to a degree as close to a cure as possible. This cannot happen if therapy only slows progressive dementia. An endpoint of complete cessation of progressive dementia, as measured by the Dementia Severity Rating Scale, DSRS, requires no statistical determination to measure an effective therapy for that patient. The rationale for this statement is provided by the Zhai et al. Article. 702 mid-intensity AD patients were evaluated over 7 years, and all were shown to have a measurable decrease in progressive dementia, measured in 1-year intervals. In other words, all AD patients decline, and if this decline can be shown to be stopped by a properly done therapy, the therapy must be effective. Based on this conclusion, this treatment combination requires relatively few test points for an effective trial with no placebo patients. A cohort of 15 patients is suggested for screening tests. Definitive results with our methodology can be attained within 12 to 18 months, as compared to up to 4 years with current standard approach. In conclusion, testing new AD therapy should consider that the disease is due to the combined effects of 4, not 1, pathologic process. These 4 should be treated by a combination of therapies directed against all 4. An example of such a combination aimed at completely stopping progressive dementia of the disease is presented. Thank you very much.